Well, hello there. Good afternoon. Hey, good to see ya. Happy Tuesday. It is, what an important day. It's March the 12th. March the 12th, 2024. Good afternoon. 4 o'clock p.m. in the Mountain Time, which means 6 o'clock p.m. on the East Coast. There is only one place to be today, and that is Fertility with Fink and Friends. I am Fink. You are friends. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado Springs. It has been a wonderful week. I want to say a special shout out and a happy birthday to nurse practitioner Brandis Montez, who graced us with being born some time ago. We won't say how many years, but thank you for having a birthday cake today. Great to see everybody. Gosh, we're expecting another big snowstorm coming here in the next few days. And daylight savings time has been, I don't know about for you, but for me, I find it to be it's a real challenge. It is nothing that I particularly enjoy. And in fact, really learned, I remember as a kid, losing the hour of sleep and having to get up on a Sunday morning, go to Sunday school was just something that was, it was just intolerable. It was just wrong. It made no sense to me. And then once you have children and you've got little ones at home who are trying to deal with who have a hard enough time dealing with life and sleep patterns as it is, and then they have to be losing an hour of sleep. It's very hard on everyone. And so, in fact, that some states, don't recognize daylight savings time as a thing. And some places do. And gosh, there's some talk I understand that they may be trying to repeal it, maybe trying to get rid of it. It was designed apparently to save some energy, but as it turns out, it really doesn't save any energy at all. That is a myth. So, wow, man. All right. What do we got going on here? We've got a couple of different Instagram feeds. We've got YouTube and LinkedIn and Facebook here in the middle. We've got my CNY Instagram. CNY's here, and this one's mine. So, hey to everybody. Let's see who was the first to join. Talita Teixeira, Miss Lovely One, and 5 others joined. Parks on the Go, I like that. Reggie, Selena, Alyssa, or no, is that Allie's Sales Lab? I'm not sure. Maybe that's Alyssa Less. I think that's what that says. Hi. Veronica Cole. Hello to Amber Vince in Kentucky, who is 20 weeks pregnant now, I am happy to say, and our thoughts are with you every day there, my friend. Let's see, Ray Day and Chanel 5, Karan 33. Let's see, Brooker Johnson, nice to see you. Pretty ass trucker, it's always good to see. Dr. Fink, where did you get those glasses? That comes from Whoopsie Daisy. Those are great. Thank you. You know what? I try to wear different glasses all the time because you know what? If I'm wearing, scrubs and whatnot to work every day, you can't really dress up your outfit when you wear PJs to work. So all I can really do is fun socks. So I try to, dress it up with the socks and change the glasses around. So thank you very much, Whoopsie Daisy. And let's see over here on my side, Lauren Sisk, who I talked to just yesterday. Hello, nice to see you here today. Tiffany Sunkisku, I believe that says, was the first to join over here on mine. Thank you. And a special hello to Angela up in the great state of Minnesota, and taking care of all those wonderful people with heart problems up there. That is a true, you are a gift to them. So thank you for being there. Hello from Atlanta there to Tiffany. Hello to, my friend Zenaida in sunny South Florida. Or is it rainy South Florida today? One never knows. It's not the summertime. If you're not from South Florida, people think, oh, what a great time of year to go visit there. Not so much because it gets pretty hot and pretty humid and it thunderstorms every afternoon. Katie Flores is with us. A special hi there to Brandis, who we just talked about. Happy birthday. Nina Buena. And Brandis said thank you. Oh, looky here. Amber says happy birthday. Now, you know what? The rest of this feed is all going to be everybody saying happy birthday to Brandis. So listen, I want to tell you, they dressed up her office so nicely today. It was so beautiful what they did in there. And I recall, well, for my birthday, I had a half deflated balloon and one streamer, and hers looked like the Ritz Carlton or the Taj Mahal. So we can tell who's more important around here. Crystal Haybear, thank you for being here. Monica is here. Let's see what else we got. Gosh, all kinds of folks. Let's see if we can hit a question here for starters. Well, you know what? Before I get to there, let me just say hi to my friends over on Facebook and YouTube and LinkedIn. Jessica, we've got Karen, Shannon, Ludi, and April. We'll get to your questions there in just a moment, but we'll start here with Nick Batez. Hello there. Scheduled a laparoscopy and a hysteroscopy before our first transfer in May. What's the recovery time on that? And how long do I have to wait for a transfer after the procedure? So a laparoscopy is, of course, where we take a camera and place it through the belly button inside to be able to take a look around inside the pelvis. Really what we're looking for there is endometriosis. That procedure probably takes, a diagnostic laparoscopy on the order of the operative time is probably 20 minutes, maybe 30 minutes, maybe even less than that. Truthfully, there's a lot of time in getting in the right spot and getting cleaned off and getting, asleep and comfortable and so forth. But the actual operative time on a laparoscopy is pretty limited. When you're done with the laparoscopy, the biggest thing that you're going to feel is that we put some gas actually in the abdomen in order to be able to see the organs, to look around on the inside. The air gets trapped underneath the diaphragm. Now, we don't have nerve endings in the diaphragm, but the diaphragm, which is what makes us breathe, is innervated, and we get what's known as referred pain. The diaphragm is being triggered here, but we feel it up in the shoulder. So you get some shoulder pain, and you kind of wake up from your laparoscopy, and you feel like, man, do I have a crick in my neck? Do they have me laying funny there? And that's really what that's all about. The recovery from a laparoscopy is pretty fast. Most people are able to kind of go back to their normal activity the next day. If anything, you take, I like to do them on a Thursday. So then you take Friday off, and then you've got the whole weekend. By Monday, you can really go back to normal. And a hysteroscopy, same thing, place a camera through the cervix inside the uterine cavity. Take a look around, depending on what's done there. So, if there's a little endometriosis and it's removed by laparoscopy, I would think that you should be able to proceed with your embryo transfer in the next cycle. If on the hysteroscopy, there is a polyp, which is a fleshy growth, if we remove the polyp, you can do your transfer next cycle. If there is a fibroid, which is a ball of muscle on the inside of the uterine cavity, and that has to be removed, generally I recommend that you wait for an extra month, so that you give it almost like 6 weeks or so recovery before you proceed with your transfer. Hello to Grayson Brock. Nice to see you this afternoon. I am old soul. Okay, I got it. Thank you. Is it possible to get a genetically normal embryo at 39? The answer is absolutely yes. Yes, 100% you can. Now, I would expect that at 39, probably about, I'd say 20 to 30% of the eggs that you are making will be chromosomally normal. You need a chromosomally normal egg in order to make a chromosomally normal embryo. But yes, absolutely it is. And, obviously we see people who are 39 getting spontaneously pregnant all the time. So I'd say that odds are in your favor there, my friend. Let's see, over on the CNY here, Veronica Nicole says, thank you so much to CNY Colorado Springs. I'm now my second trimester with my embryo transfer. Prayers are answered. Thank you so much. That is the best news. Thank you so much for sharing it. We cannot wait to see your baby picture. That is just awesome. Haley's Mama 13 says, how long do you recommend waiting to do another transfer after giving birth to my CNY baby? It's a very good question. So again, what I like to remind people of is that the only preventable risk factor for severe preterm birth is a short interconceptual interval. So we don't want you to get pregnant right away because that's really not very good for you. I'd say the minimum, ideally, it's about 9 months. There's some people who say, well, at 6 months, you can come into a transfer. I recommend 9 months. If you had a C-section, I would suggest that you move that out to about a year or 12 months. Good to hear from you, Haley's mom. Let's see what we got over here on the Facebook side. Jessica's asking, does a mini stem mean less eggs? I'm worried that a mini stem won't be enough for me. Even though my AMH was 4.58, I did not have good stimulation results with past medicated cycles for IUI, even on high dose of Clomid and some cycles high dose letrozole. I only ever grew one mature follicle. Does every mini stem have letrozole used? So no. Well, yes and no. Well, okay. So here we go, Jess. Your AMH is 4.58. And what that tells me is that your ovaries are going to respond really well to your ovarian stimulation. Not so much necessarily to Clomid or letrozole. Those may only give you, one or two follicles perhaps. I would suspect with an AMH of just about 4.6, with a standard dose, with a mini dose, you may very likely get to, 30 eggs. I think you'll probably do very, very well. The purpose of letrozole in that situation is to help to keep your estradiol level low. Letrozole artificially lowers the estrogen level in the body. So technically speaking, when your estrogen level is low, your body makes more of the hormone that's known as FSH. FSH, follicle stimulating hormone, tells your body to make more follicles. In other words, to make more eggs. If the estrogen is low, it wants more estrogen. How do we get more estrogen? We get more estrogen from those eggs in the ovaries. So that's how letrozole is involved in ovulation induction, but really and it may help to also, help to recruit some eggs. It does help to recruit some eggs with IVF. But really the reason in your situation there, Jessica, is because we want to keep that, you are at risk for ovarian hyperstimulation syndrome. And so we want to keep that estrogen level low so that your estradiol doesn't get super, super high, which makes you retain a bunch of water and also contributes to, kind of huge ovaries and being sick. So in the olden days, ovarian hyperstimulation syndrome would put people in the hospital every single day. I remember my past colleague from here telling me that when he was in his training in the 80s and in the 90s, that there was never a week that went by that someone wasn't in a coma in the ICU from ovarian hyperstimulation syndrome. And that doesn't happen anymore. We know how to manage that. So I would stand by a mini dose for you, Jessica, there, because we don't want to overstimulate you. When we overstimulate you, you produce a lot of eggs, but guess what? You're going to produce a lot of eggs anyway. And when you produce a lot of eggs in OHSS, ovarian hyperstimulation syndrome, you end up producing eggs that are just not of great quality. You end up with quantity over quality. So really, for safety's sake, we want to lower the dose in you so that we don't get you too overstimulated. So I think a mini stem is going to be probably the best answer for you. Karen says, is it common for estradiol to increase blood pressure? Any way to mitigate this? Not so much. Now estrogen in the body can cause you to retain some water. And if your intravascular blood volume increases, that can mildly increase your blood pressure. But I would not expect that to be anything of great significance. So if blood pressure is really going up during the process, then I think there's something else that's going on there, Karen. So I really, don't want you to think that's not a common scenario in stimulation for fertility. Shannon asks, I have a subchorionic hemorrhage. I'm 10 weeks and it's taking up 50% of my uterus. They said if it gets bigger, I could lose the baby. They're not very helpful. Sounds like it. Is there anything I can do to help? Well, so a subchorionic hemorrhage happens when, so here's the wall of the uterus, okay? And the placenta sits right here. As the uterus grows, the placenta moves. Uterus grows, placenta moves, and it can shear off a little space underneath here. And that creates a collection of blood or a bruise. And that's what's known as a subchorionic hemorrhage. Subchorionic basically means under the placental layer. It's a bruise, is what you have there. Now, some people with a subchorionic hemorrhage will bleed because that blood has no place else to go but out the door, or that's just kind of an easy escape for it. And that's one of the more common reasons that people will have some bleeding in the first trimester. Most of it, just like any other bruise on your body, just gets reabsorbed back into the body and it goes away. There is no treatment for it, unfortunately. Now, if you've got a subchorionic hemorrhage that is occupying about half of the space, or 50%, if you're on Lovenox, the blood thinner, then I would certainly recommend that you stop the Lovenox. I don't think that makes sense in most cases, unless you have a history of blood clotting, in which case then the benefit of being on it would outweigh the risk. Otherwise, you kind of just have to take it easy. Now, you may say, well, then I want to be on complete bed rest and I don't want to move at all. Well, guess what? The data shows us that doesn't help. In fact, it may hurt things. So it's very rare that we recommend, especially in the first trimester, that people be on complete bed rest. Just not a good thing. But what you want to do is you want to take it easy. You want to keep from overstimulating. You want to keep from bouncing around. You want to keep from doing anything that's going to stand to kind of jar things around on the inside there. Shannon, we'll keep our fingers crossed for you because that's a very frustrating place to be. But so it sounds like they're not being very helpful because there's not a whole lot that they can do. They said, oh, if it gets bigger, you could lose the baby. Well, all right. Do you really need to know that? Because what happens there, if that clot gets large enough, it can cause the placental unit to separate from the wall of the uterus, and then there's no way for blood to flow between uterus and baby. And so that's really what they're concerned about. However, there's since there's not really a treatment for it, you just kind of have to take it easy and let's roll with it, and we'll keep our fingers crossed for sure. Ludi asks, can you take 2 metformin at night? The answer is yes. If you're taking the extended release version, and it's or what's called metformin ER, and that's usually how I prescribe it, and I recommend that they both be taken at night. So usually when you start metformin, I say you want to start with 1 at night for the first week, and then you can increase it to 2. If you start full speed ahead, a lot of people will get an upset stomach for that because the GI side effects are the most common side effect that people have with metformin, but they're really designed to be taken both together. It can be taken, in other words, once a day, generally at bedtime. If, however, you find that it's causing you to get an upset stomach, then you can split it up and take 1 in the morning and 1 at night. But otherwise, yes, take them both at night, make your life a little bit easier. Okay, Joni Rose, hello, and happy Tuesday. Thank you. Same to you, my friend. Meg Britt has a consultation on Friday in Colorado. Outstanding. Dimples May says, Doctor, can you talk a bit about Lupron? My doctor told me I need Lupron for 2 months to shrink a fibroid. I am terrified of the side effects. Do I have other options? Well, potentially, yes. So, if, sometimes we will use Lupron Lupron is a medication that basically turns off your hormones. And you're right to be worried about depot Lupron because it can result in, really kind of it creates a temporary menopause and can make you feel bad. Now, there are ways to mitigate that. There's something that's called add back therapy. And that's where we give you a little bit of usually some progesterone hormone back, which helps to prevent you from having these awful side effects. So if you're going to use Lupron, then I would say ask for the add back therapy. I think that's important. But I would say also, I'm a little confused as to why you're using Lupron. We will sometimes use Lupron in order to shrink a fibroid to the point where it can, when we're going to remove one, when it can be when we may be able to take what otherwise would require an abdominal surgery, like an open incision, that we may be able to do it laparoscopically, so kind of through the belly button, minimally invasively. So that's one reason to kind of shrink a fibroid. When folks have adenomyosis or endometriosis, we will typically use some medication like Lupron in order to suppress that endometriosis for 60 days or 2 months before doing an embryo transfer. But Lupron will not have a good long-term effect on doing anything really to a fibroid. So it'll shrink it temporarily, but as soon as you're done taking it, that fibroid, its growth is going to come back. So I'm not sure if you're doing that for fertility reasons or gynecologic reasons, but I have some concerns about the story you're telling me there. Add back is what you want to know. Hello, Mrs. Tara Whitmarsh. History of 12 losses, 4 out of 8 failed transfers. I have 2 4cc and 2 1bc embryos left. I've been doing IVIG consistently for almost a year. Would you recommend 2 or 3 embryos for the next transfer? I think that you can, so in your situation, I think you can transfer at least 2. Would make sense. You would be within the guidelines given your history. Would I transfer 3? That may be a taller order. And we generally recommend people not go so much by the embryo grading because the grading doesn't correlate with the outcomes. So now I know you obviously, and so I think I would think 2 embryos certainly makes sense in your situation. Hi to Honey Girl 931. Oh gosh, I'm Old Soul asked about euploid embryos at 39 years old. Honey Girl says, yes, I got 5 of them and I'm almost 39. So that's fantastic. Tiffany says, what are the 3 essential vitamins you recommend for egg rejuvenation in women 40 plus? Okay. Excellent question. And this is going to lead me to segue into another topic here too I want to mention. But to answer your question, if I was going to say the 3 most important things, the 3 most important vitamins for egg quality in women over 40 is going to be your prenatal, it's going to be CoQ10, and it's going to be DHEA. The CoQ10 in ubiquinol form should be 200 milligrams twice a day. If it's the non-ubiquinol form, which is called ubiquinone, then that should be 600 milligrams a day divided into 2, so 300 milligrams twice a day. And the DHEA should be 25 milligrams 3 times a day in general. Those are the 3 most important things for egg quality women over 40. I have written a book on this very subject, and it's almost like you read my mind. The book is called The Vitamin Victory, and talks about natural ways to be able to improve egg quality. It's all part of the evidence-based protocol, and that ebook is available through the link that is on my Instagram. That's Randy Fink MD, and that's called Linktree. And if you're familiar with Linktree, it's linktr.ee, Linktree, linktr.ee/Randy Fink MD. And that will take you to a link where you can get a hold of that book. That book also, it's $7. So it's well worth it. That book will also entitle you to a 10% discount, free shipping, and the ability to offer that same discount to all of your friends as well. So if you want to take a look, try to make it very easy, very straightforward, very clear about what the supplements are, in which situation for egg quality, for special cases like women with diminished ovarian reserve and women over 40, women who have responded poorly to IVF before, the special cases for embryo transfer protocol, for endometriosis. It's spelled out very clearly. I hope you'll take a look at Linktree, linktr.ee/Randy Fink MD, or if you forget that, it's just the web link that's on my Instagram that will take you to that. I've also written an ebook and narrated it myself, which I've gotten some really wonderful feedback on, and I hope you will avail yourself of that. And that's called Fertility Simplified: Real Stories, Real Hope. If you are familiar with my work here, we really try to, well, look at the sign behind me here. Kindness, love, and hope, I think, is a wonderful way to try to live a life. So we talk about 6 different scenarios of fertility there that may resonate with you, things that may sound very familiar to you, and also kind of the intimacies about the struggles that go along with these fertility challenges, and really how to cope with them. I think that those are things that are not talked about enough. When you call us for consultations, where we're really looking at your stimulations, we're looking at your hormone levels, we're looking at your at the follicles, measurements in your ovaries. We're looking at things from a very technical aspect. How can we improve egg quality? What supplements are you taking? What medications? But we really leave those important things about how are you feeling to the very bottom of the list. And sometimes they really are kind of at the top of the list, and they should be. Because our feelings about how we move forward changes the way we approach every single decision we make in our lives. I hope you will avail yourself of that audiobook. Also, it's a simple little $7 thing. It's about a 40-minute listen. Just wanted to cover the cost of making it. It's something that I think you really may enjoy. So there's an ebook on supplements that includes a discount that's worth well more than the $7 it costs for the book, and the audio book, Fertility Simplified: Real Journeys, Real Stories, Real Hope. Please look at Linktree/Randy Fink MD, and consider those. I did them for you, and I hope that they are things that you will enjoy. Well, you know what? And I have to say, thank you, Tiffany, for reading my mind, because that was the perfect segue to be able to talk about that. Hi to Krishna. Any ideas to improve egg quality in PCOS? I did a mini stem. Got 23 eggs retrieved, 8 mature, 7 fertilized, only 30% of the eggs fertilized, and I am 39. So, Krishna, the first thing I would say is metformin. So if you believe it starts with the egg, if you believe the evidence-based protocols, and you'll also see that written about in my ebook there, the supplement that you would use is myo-inositol, and that's 2 grams or 2,000 milligrams twice a day. That will help egg quality in PCOS. Now, I personally believe in metformin, which is a medication version, really, of the same thing, of the metformin. Metformin's a medication version of kind of what myo-inositol does. Metformin tends to be a little cheaper because it's a medication, and your insurance will cover it. Even if it doesn't, it's probably $10, $12 for a month's supply, whereas the supplement, may end up being $25 because it's a supplement. But in a pharmaceutically manufactured medication, we know what's in every pill, because the FDA is involved in in quality control in the manufacturing. So we get a lot of reliability in the manufacturing of drugs that may just not be there in the manufacturing of supplements. And so therefore, I generally recommend the metformin. In fact, there are many sources. One of my beloved colleagues in New York, Dr. Corley, in Syracuse, feels that everyone with an AMH of greater than 3 should be on metformin specifically for egg quality. Metformin is medication that we use for folks with diabetes. We use it in PCOS in folks who are doing ovulation induction in order to help them to ovulate, and specifically in IVF, we use it for egg quality in those who have higher AMH, as well as for those with a diminished ovarian reserve. So it has something to do with signaling within the cells in order to affect the way our DNA repair mechanisms work and to be able to recruit really the healthiest eggs. So Krishna, 100%, no question. It would either be myo-inositol as a supplement or ask for the prescription of metformin. By the way, as it pertains to myo-inositol, there's another type of inositol that's called dechiromyo-inositol. That's not the one that I'm talking about. That can actually have some harmful effect on egg quality. So I generally recommend evidence is really better on straightforward myo-inositol. Hope that helps there, my friend. Let's see. April is here, and April on Facebook says, I'm having a salpingectomy Thursday due to bilateral hydrosalping. So that's fluid in the fallopian tubes. When the fluid collects in the fallopian tubes, we don't want that fluid to be there, because that fluid can wash back into the uterus and can be toxic to the embryo. It can kill an embryo. So when we find that someone has a hydrosalpinx, we remove the fallopian tubes so that it doesn't kill embryos when embryos go inside. This is my second attempt. We're trying a lower laparoscopy or C-section style if it doesn't work, again, due to a frozen pelvis. I'm afraid it's not going to be successful. Any advice to give prior to the second attempt? Well, April has a situation of what we call a frozen pelvis. And what that means is that there's so much scar tissue that the planes on the inside are really destroyed. So it takes an extremely, extremely skilled surgeon to be able to identify the anatomy and to fix what needs to be fixed. That's not a beginner's procedure. In fact, in most situations, because there's so much anatomy that's going on down there, it's not just uterus, tubes, and ovaries. Mostly what you have down there is bowel. And so there's so much intestine that's involved in the pelvis there that when all the intestine and all the omentum, which is a fatty layer on the inside, and all that peritoneum, all that tissue is stuck together, it can be very dangerous to try to manipulate sharp objects around when you're going in through the belly button. So it sounds like they're going to look from a different angle. They're going to look from a different place. In most situations where I have operated on someone who has what's known to be a frozen pelvis, we will call a surgical specialist into the room, which is usually a GYN oncologist. So those are cancer specialists who are accustomed to dealing with, really surgical disasters. They are frankly the point of last resort for us in gynecology, because they are the surgical experts. Cancer surgery can be very, very complicated, very difficult. So with a frozen pelvis, they're used to dealing with these bowel issues, or certainly at least doing it with a general surgeon who can help to make sure that the bowel does not get injured. So best of luck there, April. That sounds like a kind of a big to-do to have to go through, but I hope it all works out very well. I understand why you're nervous. Lindsay said, so excited for a transfer on the 18th, and we are excited for you too. Hi to Ethan Lucas. We had day three embryos transferred today. Yes, awesome. They were all 3 AAs, and 2 were 7 cell, 1 was 8 cell. What are the chances we have with all her blood work and levels and lining being great? Well, really, the precise answer to that question has to do with age, because the success of an embryo transfer is always going to be based on the age at which the egg was retrieved that resulted in that embryo. But across the board, generally, we would say that a day 3 embryo gives you about a 15% probability of pregnancy. So best of luck with that. You put 3 in. So, generally speaking, if we follow the guidelines and we're allowing you to place 3 embryos back inside, we are of the belief that all 3 are probably not going to stick. We don't want you to even have twins, right? Twins is not something that we're after. So we certainly don't want you to have triplets, right? So the guidelines will say that it's safe and it's okay for you to put more, to put 3 embryos back in. Typically, if you're over 38 years old and you have day 3 embryos, 3 is within the guidelines. Because the odds of all 3 sticking are probably not that high, because we said before, well, 38, 39, we expect 20 to 30% of the eggs to be normal, so 20 to 30% of the embryos to be normal. So hopefully what we're hoping for is that of those 3, you're putting 3 in so that it increases the probability there of a positive pregnancy test. So fingers crossed there, my friends. Shannon says, I got 27 eggs on a mini dose and 13 were mature. So yeah, mini dose therapy will do the job if your ovaries are paying attention, It looks like area, I think that says, I have an AMH of 6.2. Which bundle is best for me? That's going to be the mini dose bundle. So again, when that AMH level is a little higher, we are generally going to want to drop the dose. We want to lower the dose so that we don't create a situation of overt ovarian hyperstimulation. This whole process of IVF is what's known as controlled ovarian hyperstimulation. You might see it written sometimes, COH, controlled ovarian hyperstimulation. So a mini dose would be proper for you, because if we use a higher dose, it's going to be uncontrolled ovarian hyperstimulation. So good deal. Nicole asks, what is the best protocol for transfer for PCOS for someone with a 25 BMI and a history of miscarriages? So certainly it would be the embryo transfer a supplement protocol, which includes prenatal vitamin D, vitamin E, CoQ10, and L-arginine. Please see my linktree /Randy Fink MD, or look at my Instagram page to find that link for the ebook I've written that goes over those protocols, please. But basically your option is either a medicated cycle or a natural cycle. And I'm a fan of the natural cycle. In your case with PCOS, we probably want to use a modified natural cycle, which means we do some ovulation induction. That'd be giving you some letrozole just to make sure that the ovaries are going to respond and make a follicle with an egg inside. That makes your estrogen. We trigger the ovulation so that you will make your own progesterone. My recommendation is modified natural, but the standard, the standby, and in fact, the overall, default, unless we say otherwise, is always going to be a medicated cycle, which is where we're giving you all the estrogen and all the progesterone, all the hormones that you need to be pregnant and stop your body from making it. Why do we do that? That's the way they've been doing it in IVF for 40 years, because we can control every variable there. The modified natural, there's some data. The data shows it's very clear. It is at least as effective, and in many cases may be more effective. There may be a higher pregnancy rate, a lower miscarriage rate, and a lower risk for certain pregnancy complications. So I believe in the modified natural. if we can do it. Let's see here. What do we got? Do the IVF meds make you nauseated, and what are the side effects? Well, I think, to be honest with you, any medication can make you nauseated. Nausea is more likely to occur as your ovaries get larger, let's say around the time of trigger and in the day or so before your egg retrieval. But nausea, like, oh, I just took a little medicine and I got super nauseated, is not something that we commonly hear. But, nausea is going to be on the list of potential side effects for every medication that has ever been created. If you look at the package inserts, you will see, people get nauseated, people get headaches. Nausea and headache, number one, number two complications, or rather side effects, really for just about every medication ever made, including vitamins. So what does that mean? Well, it probably doesn't mean a whole lot. But nausea is not uncommon right before egg retrieval when the ovaries have gone from, really kind of walnut size into, sometimes even cantaloupe size. So big ovaries can make you nauseated. And that's why when we find that that's the case here, we often send you home with some anti-nausea medication. Adults don't do well with nausea. I always say little kids can puke and be back outside playing again in like 20 minutes. Adult, if you're nauseated, we're on the couch for the rest of the day. We don't like it. So, Meg, we try to keep you from being nauseated if at all possible. Reggie Salinas said, I've been diagnosed with diminished ovarian reserve at 28 years old with an AMH of 1.4 and an antral follicle count between 12 and 16. I've been trying for 2 years with one failed medicated timed intercourse cycle. Thoughts? Well, so I would certainly, Reggie, think about stepping it up a notch. If you've been trying, we know that 85% of couples will conceive within 1 year of appropriately timed intercourse. And so, if it's been a year and you've tried for 2 years now, you're kind of a little bit behind the curve. I think it would make good sense to step it up a notch. IUI is a very simple process, low invasive, low cost. It has a significantly higher success rate than home intercourse or even timed intercourse alone. And if that's not effective, IVF is extremely effective. I wouldn't do tons of cycles of IUI, Reggie, there. So at 28, an AMH of 1.4 is lower than expected for age, but it's still not bad. I would say that you are likely going to still respond very well to medications. I think you have a very, very high chance, very high probability of getting pregnant. So please don't give up. But I think it's probably time to step it up. Let's see, it's almost a quarter till the top of the hour, so we're here for another 15 minutes or so. Let's see if we can get some more questions in. My period, this comes from Faith. Hey, Faith, my period is supposed to start in a couple of days, and I'm so excited and nervous to start this roller coaster again. Well, welcome to the ride there, my friend. We are here riding with you. Can MTHR, this comes from Maria, affect the success of IVF? And do you recommend getting screened for it prior to starting IVF? Absolutely not. So MTHFR stands for is a genetic issue that causes the way you metabolize your folic acid to be a little different. It's called it's an enzyme. It's called methylene tetrahydrofolate reductase. And if you have an MTHFR deficiency, it used to be thought that that was one of the causes of recurrent pregnancy loss. We have now learned that it is not. It's actually very common in the general population. There used to be some specific recommendations about it, but basically now I would say that as far as the folic acid, I would have you take the type of folic acid that's called 7-methyl tetrahydrofolate. 7-methyl tetrahydrofolate, which is a particular type of folic acid that you can absorb and metabolize a little bit better. Folic acid is important for a lot of different things, most specifically for preventing what's known as neural tube defects in your offspring. If you, I think 7-methyl tetrahydrofolate is an appropriate folate for everyone. That's just the folate I would use. And if you're, get it in your prenatal vitamin, take it as part of your prenatal vitamin. You don't need extra folate in the general population. So no, I would not recommend MTHFR testing really for just about anybody, certainly in the obstetrics or in the fertility world. Okay, I'm a quick ovulator. Is that an issue in IVF? That comes from Joni Rose. Not so much, because we follow. We're giving you medications to stimulate those eggs, and we put you on medication that will stop you from ovulating, because we don't want you to ovulate until we're ready to get those eggs, because we want them. So we trigger the ovulation when we're ready, and you're on medication that's called an antagonist that will stop you from ovulating. So nope, shouldn't be an issue there. Hi to Shelby Lynn. Equestrian says, do I need intralipids for retrieval or just transfer? Just transfer. That's intralipid is an infusion that is designed to be an immune modulator, and it is used prior to embryo transfer, not for egg retrieval. Do you stop taking L-arginine after transfer? This comes from Iandre. Hello, my friend. Good to see you. Yes, L-arginine. Well, you stop with your positive pregnancy test. So L-arginine is a supplement that is part of the embryo transfer protocol. It is absolutely 100% not part of the egg quality protocol. So please make sure you're not on L-arginine during your stimulation, or any supplement that contains L-arginine during your stimulation. But yeah, typically you stop it when you get your positive pregnancy test. Raleigh Trolley says, hi, Dr. Fink. I previously took a thyroid medication, but have been off of it for almost a year due to blood work results. Would it be okay to take? Well, so, if you're doing fertility treatments, we're going to test that. We're going to see where your TSH is. The TSH is the thyroid stimulating hormone. And that is that's the measure of what your thyroid hormone's doing on the inside. So easy enough. We want that number to be between 0.5 and 2.5. If it is higher than 2.5, the higher the number, the lower the thyroid function. Just remember my finger. The higher the number, the lower the thyroid function. So if your number is above a 2.5, we're going to put you on some thyroid medication, because we want to get it within that range. Optimized for fertility is between 0.5 and 2.5. So I just say check it and see. I would not recommend that you just start it outright if you've been off of it for a while, because it may be something that you don't need. Allison BC said, I did my first retrieval yesterday, got 20 eggs, but only 6 mature and 3 fertilized. Should I consider another retrieval? My answer would be yes, because again, the goal of IVF here is to maximize the number of eggs in order to maximize the number of embryos, in order to maximize the number of options. Simple as that. It's a numbers game. So, yep, absolutely. In that situation, Allison, I would probably want to take a look and see, number one, when did they trigger you? Maybe you could have gone a little bit longer on a trigger, and before you triggered, and you might have gotten a few more mature eggs. But I suspect that may have been a PCO type situation, where again, we're getting quantity over quality. I'm wondering about metformin for you, and I'm certainly wondering about the supplement protocol for egg quality. Yeah, for sure. Let's see. I previously took, I see. You took the thyroid. Would it be okay to take alpha lipoic acid? The answer is yes. Yes, it is okay. Shelby Lynn says, I was on 75 milligrams of Menopur and 150 of Gonal. We got only 2 eggs last time, but they doubled my dose this round. Will that help with more eggs with an AMH of 1.2? So you're on 150 of Gonal, 75 of Menopur. That's a pretty low dose. And so now they have doubled the dose. So you're on 300 and 150. Even 375 probably would have increased your outcomes, I would bet there, Shelby. So yeah, I think you're going to be doing better there. Siciliana Melissa said, endometriosis suppression prior to an embryo transfer. is 150 milligrams of Orilissa alone enough? Was prescribed letrozole, but told to stop taking it due to side effects. The estradiol level was below 5 while on both, and the FSH was 16. Yeah, Orilissa alone, I think, is enough. There's not good data about using letrozole with Orilissa. There is some extra data about using letrozole along with Lupron. So it's a little bit of an extrapolation to say, hey, we should put letrozole with Orilissa as well. But the goal of Orilissa over Lupron is to try to get you some, a lower side effect profile. And so to add letrozole with that makes it kind of hard to tolerate, for sure. But yes, I think Orilissa alone is probably enough, although I typically use 200 milligrams of Orilissa, which is twice daily, as opposed to the 150, which is once daily. And I personally don't use the letrozole. So but I think you'll be okay. Doesn't matter what cycle day you start. This comes from Ash. You start your Orilissa. I started mine on cycle day 1. No, that's perfect. So if you're starting cycle day 1, it'll decrease some of the irregular menstrual bleeding that you'll have during the cycle. So, yep, you're in good shape there. Emily Wen is here. Consultation in early April. When do I start the keto diet? Well, so if you are a follower of Dr. Kiltz, you will know that you should have started the keto diet the day you were born. I wish he was here to hear me say that, the sooner the better. Keto is high fat, moderate protein, and low carb. The thing that we all certainly agree on is that carbs are pro-inflammatory. So anything that we can do to decrease the carb load, decrease carbs, is probably going to decrease inflammation, and that the the high fat portion is actually anti-inflammatory. So I would say the sooner you can start keto, if you believe, the better off you are. And I would strongly encourage you, Emily, there to please search for Dr. Kiltz's work on the matter and look at some of his lives, because he really is the guru as it pertains to keto and carnivore. Hi to Danny Dancer. I do like that name. New Mrs. Gorgeous Georges. Do you suggest HCG boosters after suppression for a mosaic embryo? So HCG boosters are very useful in those who have done a natural or a modified natural FET. In a medicated cycle, they probably don't do very much. What they do is they're metabolized in the body to give you more progesterone. In a medicated cycle, we are giving you so much progesterone that extra progesterone probably doesn't really, through the progesterone and oil shot, we're really able to maximize what you get in terms of progesterone. So with a natural cycle or a modified natural, that's when HCG boosters are a benefit. After suppression, I think of it, yes, I would say yes if you're doing that modified natural cycle. And the mosaic, the recommendation is not specifically for the type of embryo being transferred. But I think as long as you're doing that modified natural after your suppression, HCG boosters do make sense. Hello, Lou says, is follistim at 225 too high for someone who has unexplained infertility? Well, it wouldn't relate so much to the cause of your infertility, but the dosing of follistim, your FSH hormone or gonal-F, is really based upon how we expect your ovaries to respond. So number one, it's based on age, and with a secondary factor of, that was weird. I just held up my thumb and it put this like little thumbs up emoji on there. That was bizarre. It's based on age and based on AMH, but not based on reasons for infertility. So for instance, it's not uncommon that I will talk to someone maybe who's had their tubes tied, and she will say, well, I don't have infertility, I just had my tubes tied, so I really don't need much medication. And that's not a thing, because your body is going to respond based based upon really what your age is and your AMH, irrespective of the reason, whether you're doing it for gender selection or you had a tubal or the fertility is unexplained. Okay. Is there a generic for Zomactin? Zomactin, so that's growth hormone. I believe human growth hormone is only in their brand names, but there's a number of different ones. The problem with human growth hormone is that it's kind of expensive, right? And maybe that's why you're asking, is there a generic there? Yeah, it's pricey, but I really do think it makes a difference. The one we principally use is Omnitrope. Omnitrope has been harder to find as a result of some manufacturing things. So Zomactin is kind of a secondary. The other ones I think actually may be more expensive than that. So, but I don't believe there's any specific generic. I think they're all brand named. Danny McPherson says, I have a low AMH and hoping to do IVF in May or June. Do you recommend the ovarian rejuvenation procedure? So that is known as intra-ovarian PRP. It is considered experimental because we don't know, the data is still out on what's the ideal interval before, when should you do it before you do a treatment? How many treatments do you do? So many questions about it, but I do think it is a worthwhile thing. I have seen it make a big difference. It takes about 2 minutes to do. It actually takes about an hour to make it in the lab, but the actual injection is very, very fast. It's done under some anesthesia, so you don't feel a thing. And I generally recommend that folks do it about 4 weeks or in the month before they intend to do their stimulation. So I think that's probably the ideal timing there, Danny. And I've seen it really make a difference in outcomes. Of course, it varies. Every person is different, and some people do better than others. But in order to try to improve the egg quality in that situation, yeah, I do think it's a good idea. Oh, let's see. What's the best protocol? This comes from Nicole on Facebook. The best protocol for transfer. Oh, I think we answered that. Everything he is saying happened to me. I don't remember what I said, but Christina is agreeing with me. So thank you for agreeing. I had, this comes from, looks like Kelsha. I had a Mirena that stopped my period for 8 years. Recently had it removed on February 7th and still no period. I took an FSH and AMH. Results came back. FSH is 55 and AMH not established. I have a consultation with you in May. I'm 46 and I had 4 natural pregnancies, so no past infertility. Can I still have successful IVF? I'm feeling very down. Could it be because my body's hormones are not back to normal? Well, so an FSH of 55 is considered a menopausal level of hormone. And it may just be that the ovaries ticked over into that stage while you were on the Mirena and you weren't getting periods, so you didn't know. I would say under those circumstances, it's going to be difficult to do IVF with your own egg. Because you may not have many eggs that are recruitable. If the AMH was kind of undetectable, that's saying that your ovarian reserve may not be sufficient to be able to give you medications to retrieve an egg. And one way to think about that is that if the FSH level is high, well, the medication that we're doing is FSH. And if it's already high, then we may not be successful in getting an egg. But I'm glad there, Kelsha, that you have a consult, because there may be some things that we can do to try to improve that. You may be kind of on the border. And so we may be able to kind of push you back, reel you back in towards this side of things. So we'll keep our fingers crossed there. Mary says, for a donor egg fresh transfer, do you recommend day 3 or day 5? Well, if you have a day 5 embryo, you're always going to have a higher pregnancy rate, because that embryo has grown from being a bunch of little cleaving cells still trying to figure out how to divide, all the way into a little functioning piece of machinery there. So if you can get to a blastocyst stage, that's generally going to be a higher pregnancy rate if you can. If you're limited in the numbers, then I would say, day 3 is fine, because I'd much rather see that embryo going inside of you where it has a chance to grow than necessarily growing in the lab. So there is nothing in the world wrong with a day 3 embryo. So I think we are gonna, gosh, it's top of the hour. We're gonna be out of time again for a Tuesday, but we'll certainly be back here next Tuesday at 4 o'clock in the Rocky Mountains and 6 o'clock on the East Coast, 3 on the West. Hopefully we're gonna get some snow this week. Well, at least over here. I guess if you're in South Florida, you probably don't want so much snow. I don't know if my mom and dad are watching, but a special hi to them. And again, a happy birthday to Brandis. Please take a look at my ebook about the supplements, which comes with the discount program, and also my audiobook about Fertility Simplified, just kind of surviving the fertility life there. And that link is linktree, linktr.ee /Randy Fink MD, or it's the link that's on my Instagram page. I hope that those are things that you would enjoy, and I certainly would appreciate your feedback if you do have a chance to listen. Hey, every day is a new journey. Every day is a new adventure. And so each step we take forward, please do it with kindness. The world needs more kindness. Do it with love, and do it with hope, knowing that tomorrow may be completely different from today. And this whole fertility business, it's not your novel. It's not your book. It's just a chapter. And what we're doing is rewriting it. And we're doing it together. Thanks for being here. I wish you all the best. Have a great week. God bless. Good night.